Welcome to another CME session from SJMC. We hope you enjoy the content.
Thank you very much for joining us for yet again. We had a break last month when there was actually a real grand rounds and teaching session, which was very successful. So we are resuming the SJMC virtual grand rounds. This is the 31st cardiology grand rounds. And with me today, Dr. Kanan. Dr. Kanan, can you hear us? Can give a
Yes,
wave?
I can. Yes, I can.
Yes. And Dr. Choi and Dr. Koh. Okay, so three cardiologists from SJMC will be sharing uh, interesting cases. And the topic today is when a persistent cough is not due to lung disease. So there are very interesting cases each time. So just to highlight to you if you got questions, please feel free to ask us on Slido. If you have the Slido app on your phone, you can enter 4142879. Otherwise, just use your QR code scanner, not the MMA app, the QR code scanner, and scan this, and it will take you to the Slido website or the Slido app and to where you can ask questions. If you're watching this in our DOPS webpage, the Slido is already embedded there. So yeah, feel free to ask us. If you do ask us in YouTube, we will be able to see that too. But we prefer you to use Slido. Now, this session will make this eligible for 1 CBD point. So at the end of the session, we'll post a link for you to submit your attendance. And we'll elaborate more on that later because, as you know, the MMA has disabled the sharing of a QR code in the presentation for you to scan with the MMA app. So we have to mark attendance at the end of the talk. Okay, so without further ado, I'm going to pass you over to our chairman, Dr. Kanan, and I'm going to switch the slides to Dr. Kanan. Over to you, Dr. Kanan.
Okay, thank you. Can you see my slides?
Yes, yeah,
okay.
Definitely.
Right. Good afternoon, ladies and gentlemen. Thank you for joining us again on a Saturday afternoon. So with my colleagues, Dr. Choi, Dr. Koh, we will be presenting three cases. So you can think, so that you'll be able to think of a differential diagnosis when a patient comes presenting with a persistent cough. And as you all know, of course, cough and especially persistent cough are very frequent things that we see in our patients, especially in general practice. I'm going to present the first case, followed by Dr. Koh will present the second case, and I will appear again for the third case. Now, this patient was seen in November of 2023, a 74-year-old Chinese lady who presented in the emergency room with a 2-week history of cough with some yellowish sputum. There was no fever. She complained of some breathlessness on exertion. And for 1 week, her cough was worse on lying down, and she felt better on sitting up. She had no history of diabetes or hypertension. Treatment, she was on nebivolol, a beta blocker, 1.25 milligrams, daily, started after a diagnosis of myocarditis 10 years ago at the Assunta Hospital. She had a coronary CT angiogram done in March of 2022, and this was surprisingly completely normal for someone who was 74 years old. She had been seen in the emergency room twice in the last 3 days. The medical officer's notes, as seen earlier, showed the following findings. Jugular venous pressure was not elevated. Blood pressure was 100/80. Pulse rate was 68 per minute, but we must remember that She was on beta blockers, so maybe that explains the rate. There was no edema, the lungs were clear to auscultation. The chest x-ray showed clear lung fields. So he treated her with the antitussives, antibiotics, and antihistamines. The night before she came to see us again, where I was involved, she had been awakened with cold sweats and breathlessness. There was no chest pain, and she came to the emergency room for a third visit in 2 days. When I saw her, she was pale, blood pressure was 105/80, pulse rate was 74 per minute regular. I looked for the JVP, this was not elevated. She had no edema. In the heart, we heard dual sounds, there was no gallop sound. The lungs were clear to auscultation, and the abdomen was normal. So, first question goes to Dr. Koh. Someone presents with this history and clinical signs. What are the possible causes for the patient's symptoms? Remember, this patient has received treatment for respiratory illness.
Dr. Kanan. So this is a rather actually common cases, cough, treated with antibiotics. But I think the red flag is she came to ER twice in a short span of time and not responsive to the usual antibiotic treatment. And she looks pale and she has breathlessness lying down. So there are a few differential diagnoses at this point of time based on the history and physical finding. It can be as simple as maybe this patient had anemia with a bit of gastroesophageal reflux symptom. That's why I explained that she is pale, breathlessness when lying down, and maybe associated with peptic ulcer disease or something like that. It can be as simple as that. Of course, we also think of things like acute bronchitis. That's why the lung is normal. On and off, we're having this paroxysmal acute bronchitis resolving from possible pneumonia previously. And it also can be something maybe a bit more sinister. Does he have underlying heart problem? For example, like cardiomyopathy or even inflammation of the heart, myocarditis, because you have symptom of infection earlier on. So these are my thoughts process.
Okay, thank you, Dr. Koh. So I put down some of the things that Dr. Koh has said. Okay, we'll move on. So what investigations would you like to do, Dr. Koh?
I'll do a simple investigation first, blood test, ECG, and chest X-ray. So these will probably narrow down the differential diagnosis.
Okay. I will show the ECG that we did, and Dr. Choi, can you kindly comment on this ECG?
Sure. Thanks, Dr. Kannan. So when you look at this ECG, I would like to start with the rate and rhythm first. Nobody would argue this is not a sinus rhythm. You can see P followed by a nice QRS for every beat. It's a bit puzzling for someone who is in distress to have such a normal rate. You know, if someone is breathless, usually you will expect them to be tachycardic. But in this case, maybe not too surprising because she has nebulizer on board. So maybe to take note, anyone a beta blocker, we can't just rely on the rate alone. Looking at the QRS complexes, it looks a little bit broadish. I would call this something non-specific kind of a conduction delay. Anyone with, if you suspect heart failure, of course, we look hard for Q waves or signs of ACS. But bear in mind, her CT cardiac 2022 was actually normal. And she also has T-wave inversion at lateral leads, maybe some over the inferior leads as well. These are all quite non-specific. I don't think it could indicate anything in particular. Possible LVH based on the voltage criteria. Left atrium seem to be enlarged as well. Overall, I think she could be having some kind of cardiomyopathy, but we need more tests to be sure.
Okay, thanks, Dr. Choi. So we thought the axis was on the left. The R wave progression from V1 to V4 to V5 seems to be poor. Sometimes it's an indication of an old anterior infarct, but as we saw, the CT angiogram was completely normal. So the next test we did was a chest X-ray, and Dr. Choi is still with you. Can you comment on this chest X-ray?
Yeah. So we can see from this X-ray, obviously, the cardiothoracic ratio is widened. So she has a gross cardiomegaly. You mentioned that the lungs are clear, so I can't see
Yes.
any significant pulmonary congestion as well.
Yes.
But if you look really hard, maybe especially on the right side, the costophrenic angle is blunted. Maybe she does have a bit of pleural effusion. Based on my personal experience, if you have a unilateral pleural effusion, of course, it can be infection, but heart failure should also be at the top of the list.
Okay, good. Thanks. So we agree with you about the cardiomegaly, lungs. Actually, we agreed with you there was no congestion, and both the claustrophrenic angles are actually blunted. So maybe small effusions. Yeah. So would you like to do any other test, Dr. Choi?
Okay, at this point, someone who has cough, treated as pneumonia, and still being breathless, I guess a reasonable test to do is a pro-BNP.
Okay.
Pro-BNP will give us an idea.
Okay. So that's a pro BNP for you.
So her
20,000,
pro-BNP is very high.
very high.
Yeah.
So could you
I-
tell us a bit more about the NT-proBNP and how it helps us with patient management?
So pro-BNP is actually a peptide that is usually normal in normal heart kind of patient, provided the renal function is normal. In instances where the heart is distended, stretched, like heart failure, valvular issues, pro-BNP will start to rise. And the normal value goes along with the age. As you get older, the normal value may go up. Bear in mind, if you have renal impairment, the pro-BNP may be a bit falsely elevated as well. But personally, you have a 5 figure of pro-BNP, even though she does have a bit of renal impairment, this is remarkably elevated. So it indicates heart failure in this case.
Okay. Thank you. So that's what we thought. We were quite surprised, but we went on. We did some investigations. The hemoglobin is 12.9. As we mentioned, she looked pale, but the hemoglobin is normal. We'll come back to this later. The urea and creatinine is elevated, not grossly, but certainly not normal. Albumin was a little lowish at 29, and her liver enzymes, both the liver enzymes were quite significantly elevated, 198 and 226. So still with you, Dr. Choi, does this elevated NT-proBNP give us a clue as to the cause for the patient's impaired renal function and elevated liver enzymes? And maybe I'll ask you the next question so you can answer in a row. Why was she pale, even though the hemoglobin was 12.9?
Sure. At this point, given the pro-BNP of 20,000, I think all the elevated liver enzymes, the deranged renal function, it could all point towards the same cause, which is, I feel, is a heart failure kind of etiology, congested liver, what they call it, the cardiac cirrhosis kind of event. The reason why she appeared pale, if you look at the blood pressure was a bit low at the time, she was in distress. I would believe some kind of systemic vessel constriction as part of a shock response that would mimic the patient being pale, but probably not real. When you look at the HP, it's actually normal.
Okay, good. Thank you. So we did an echocardiogram, and Dr. Ko, I hope it runs. Dr. Ko, perhaps you can comment about the echocardiogram. Unfortunately, it's not.
Sure.
It refuses to run. Let me try something. Uh-oh. I'm sorry. Let's see whether I can get it going.
No, just open back your PowerPoint. I'm sorry. PowerPoint.
I think it went off. I have to do it again.
Just open back your
Let me come.
PowerPoint.
It's
And close it. Minimize your Chrome and then run your
yeah,
PowerPoint.
yeah. I'll do that again.
Microsoft Windows for you.
I've got.
Joy was telling
One
you
second.
get a Mac.
Okay. Sorry about this. Yeah, we're coming on board.
Things happen.
Okay,
Hmm.
this is course one. Can you all see the slides now?
And
Yes, perfect.
Okay. All right, now the
give some time. Oh, yes, right. Okay, the one it is moving is a long axis view. I think the right side, the short axis view, you can see that it is globally hypokinetic, and there's no color there. Not too sure, but what I can say that is the heart, it looks dilated, especially the left ventricle, and it is globally hypokinetic. The EF is definitely on the low side.
okay. So obviously, this is someone with very poor left ventricular systolic function. So we went back on the history and we found that 10 years ago, she was treated at Asunta Hospital for cardiogenic shock. And she told us that she needed medications to support her blood pressure. And finally, she was told that she had an infection which affected her heart. She was given some medicines to support her heart. She took the medicines for 3 to 4 years and then defaulted and claimed that she had been well. In 2015, she underwent uneventful surgery for colon carcinoma, Duke stage C, but she refused to have chemotherapy, and she remained well after that. So, Dr. Koh, this patient obviously has got poor LV function. She has got congestive heart failure. You saw the clinical signs, you saw the chest X-ray. Is diuretic therapy indicated in this patient?
Therapy are usually for those with overt congestion. This lady, I think physically, if there's no basal crepitation, no edema, then perhaps may not need strong diuretic therapy. But if the patient has crepitation on the lung or peripheral edema, then probably I will give a bit of oral diuretics or even IV diuretics. And of the important thing is to initiate heart failure therapy as soon as possible and also as soon as the blood pressure allows. So there are many types of heart failure therapy, and the one I will start first is probably those who have least hemodynamic effect, means that those medication doesn't drop the blood pressure a lot. Agents like SGLT2, and also maybe start a very low dose of ARB, ACE inhibitor, or ARNI, as well as a beta blocker. And that will probably my first steps.
Okay, very good. I mean, for those of us who are really old generation like me, obviously the treatment of heart failure is a huge paradigm shift. When I was a house officer and medical officer, anyone comes in with a smelling of heart failure, the first medication we give is diuretics. And sometimes we would give as a huge dose as 80 milligrams of intravenous furosemide stat, because we had very few other drugs available to treat patients those days. But now, of course, there are so many drugs available, and certainly I agree with Dr. Koh that since we did not find any evidence of fluid overload, at least did not find any evidence of gross fluid overload, I decided not to use any diuretics. We started her on a SGLT2 for SIGA, 10 milligrams, gave her a small dose of Entresto, which is ARNI, at 12.5 milligrams. She was on nebivolol when she came to us, and we decided to continue with this. And she was admitted to the hospital. Then by the next morning, she was much better. And when we looked at the intake output chart, even though she had not been given any diuretics, she had passed out quite a lot of urine. The intake was just 250 mils, but output was 1,205. So Dr. Koh, could you try to tell us why there was this diuresis even though no diuretics had been given?
interesting observation commonly seen when patient is initiated the SGLT2 inhibitor. So what happened is this patient was on Forxiga. Forxiga, or the other name is dapagliflozin, is a SGLT2 inhibitor that exert diuretic effects by inhibiting the absorption of sodium and glucose from the proximal tubule. So this pulls out a lot of volume fluid. So you can see all these diuretic effect when you start patient of SGLT2.
Okay, good. So we'll move on. So the progress was she symptomatically improved daily. She continued to have a negative balance daily. And whenever we treat patients like this who have got very poor left ventricular systolic function, we are very careful with the amount of diuresis they have because their reserve is very small. As we know, their stroke, their cardiac output is very dependent on the rate. Here, the rate is also controlled, and the stroke volume is very small. So we try to make sure that there's no excessive diuresis. Blood pressure dropped to about 90 systolic after 2 days, and she was asymptomatic. So one of the things I worried about was the negative balance. Anyway, I stopped the nebivolol because the reasoning was that this lady's cardiac output was just maintained by the heart rate. The stroke volume was really very poor and negligible. So if we increase the heart rate, things might happen. So the heart rate went up a bit, and then I decided to give a bit of digoxin and then add a bit of ivabradine so that she would not become too tachycardic and at the same time not drop her blood pressure. And this was a serial blood test that we did. And as you can see, within a matter of 5 days, her liver enzymes had normalized. You see that there's a lot of improvement in her renal function. And what's striking is the NT-proBNP crashed from 20,000 to just below 2,000. So she was last seen follow-up on the 13th of December last year. So she was symptomatically well. In fact, her blood pressure had now gone up to 130/80 when sitting. When she stood, there was a slight drop to 120/80. Her heart rate was 68 per minute. And this was the medications that she's been on. She sees Ellen for essential thrombocytosis, so she gets clopidogrel. We continue with the SGLT2, continued with the Entresto now at a higher dose. And when she comes for next follow-up, the digoxin and ivabradine is going to be stopped and she'll be switched to a beta blocker. And I think she will continue to be all right. So I think we are ready for the next case, which is going to be presented by Dr. Koh.
The slides, you know. Okay, Ken. So maybe we move to the first slide. So I got this interesting young man, 33-year-old man that initially saw two chest physicians early last year, and he has been presenting with a cough for 6 weeks and is not getting better after the initial stage 2 COVID infection. So still having whitish sputum, but no hemoptysis, disturb his sleep, so worse when he's talking very fast. But then it's not related to co-environment, food exertion, or lying down. Now, physical examination are unremarkable, except for this guy is a very big size guy, and he was treated as acute bronchitis with inhalers and steroid therapy by the chest physician. Now, the second chest physician noticed that the heart rate is persistently on the high side. So the patient mentioned that since he got COVID infection, he always have this smartwatch telling him the heart rate is always about 110 and above. So he referred to me for actually unexplained tachycardia. So next slide. So on examination, he is mildly tachypneic at rest. You can see that the weight is 126 kg, a big size guy. No finger clubbing. Blood pressure is maintained at 120/90. Pulse rate is 110 with frequent missed beats. So this is the first abnormal sign that I can tell. JVP not obvious, lungs clear, cardiovascular, no murmur, S1, S2, no gallop rhythm, no sign of peripheral edema. Next slide. So I'll ask Dr. Kannan, what would be your thought on the initial diagnosis and maybe what investigation would you order?
Okay, quite interesting. Now, this patient has been seen by two respiratory physicians. So a residual respiratory condition seems unlikely, except that it could still be a very slowly resolving acute bronchitis, maybe with some reactive airway disease. So sometimes we refer these patients, and then when we examine, we find nothing. Yeah. So if we can exclude a respiratory cause, the next thing we have to think about is something cardiovascular based on the symptoms. So a few clues, as you have mentioned, she's overweight. It does appear a bit tachypneic at rest. There is his heart rate is a bit fast, and you say that he had quite a few missed beats. So there are some clues for cardiovascular strain. So some of the conditions we want to think about are something related to what could have started as a pulmonary infection. So we certainly want to think about myocarditis. You mentioned that he had COVID. So once we have got COVID, we have to think about cardiac-related cardiac dysfunction due to COVID. Yeah. Of course, in an overweight guy like this, he was not well. Maybe he was lying around for a while. So we have to think about whether he could now have pulmonary embolism. There's a bit of tachycardia. So thyrotoxic heart disease needs exclusion. Although him being fat, one would think that should be the other end of the game, hypothyroid rather than thyrotoxic. And both ends of the thyroid spectrum can cause cardiac dysfunction. Of course, dilated cardiomyopathy in a young man. Uh, there are no clinical signs for valvular heart disease, but sometimes we have been caught. You've got someone with severe mitral stenosis, you might not hear a murmur, and the clue might either appear in a chest X-ray where you see a big left atrium, or when you do the echo and you see a tight stenosis. So that's something that I'll keep at the back of mind. Of course, it's fashionable to diagnose tachycardia-induced cardiomyopathy in the last 10 years when you see somebody with a lot of ectopics. And you guys have taught us that it makes a difference. Some of these guys, you treat them, you can get a heart to go back to normal. So these are some of the things I'll think about. I asked about investigations. Obviously, a few simple things first, ECG, chest X-ray. Of course, our NT-proBNP will always help us as we discussed in our first case. I'm a bit biased because of the rate, so maybe a thyroid profile and an echocardiogram.
Kind of covered everything. So next slide, let's see. So I ordered all these tests that have mentioned by Dr. Kannan. Maybe we move on to the next slide, and Dr. Kannan may comment on the X-ray.
So this is obviously an enlarged heart. There's no question about it. I could hazard, I mean, I'm seeing this on the screen, but probably there might be some pulmonary congestion. I won't be surprised, like if in the old days we had floated down a pulmonary capillary wedge pressure catheter, we get a reading like 30 or 35, which is elevated. I won't be surprised. So certainly enlarged heart, maybe a bit of congestion.
Slide. So these are the reports. Heart size definitely enlarged. The radiology doesn't think there's evidence of heart failure. Clinically, not much, surprisingly. So let's see the next slide, which is the ECG. Oh, maybe Dr. Kannan, I'll ask you first. Would you order a proBNP at this point of time?
I certainly would. No question.
Yeah.
Yes.
So far, I think I will also order, because you know that when the only sign is cardiomegaly,
Yes.
physically it is no congestion. So I'm not too sure. So I think the proBNP will give a lot of information. I'll show you the proBNP result later. Let's show the next slide, which is I think the ECG. Maybe Dr. Choi can comment on the ECG.
Okay, thanks, Dr. Ko. So first, rate and rhythm. So the rate seems to be a little bit faster compared to the first case. I think it's about 100 beats per minute. You can see a lot of interpolated extra beats, which are wide. So I would say these are all PVCs. So this patient has a lot of fairly regular looking PVCs in between a fairly fast heart rate. Other than that, the PRQT looks normal. There's no real Q waves to indicate any significant coronary artery disease before this. ST segments are all normal. I just want to add that sometimes post-COVID, when you have all these PVCs, I'm not sure Dr. Cole agrees with me, but it's quite common actually. And most of the time we just assess accordingly. And some may wonder, when you have PVCs, these are all benign PVCs, right? Why are we too worried about PVCs? Now, the different thing about this ECG is that most PVCs are suppressible by tachycardia, meaning that if you work, when you walk, most of the PVCs will go away. These patients' heart rate is about 100, and the PVCs are still there. So my bet is these PVCs are not so benign after all.
Very sharp. I think you're right. So what will be your next investigation, Dr. Choi?
Yeah, so this patient has a lot of challenges on his plate right now, being like what he just mentioned. With the next test, I will probably do an echo.
Okay, maybe Dr. Allen, help me to click next.
Could I
slide
interrupt? Could I interrupt to ask a
next
question?
slide.
Can I interrupt to ask a question?
Yeah, Dr.
Choi, so to emphasize a very important point you bring up. So if we see somebody with quite frequent ventricular ectopics, especially if the underlying rate is also quite fast, then it's more sinister as compared to somebody whose ECG shows ectopics, but the rate is quite normal or rather slow. Would that be right?
Said anecdotally, because most of the PVCs that are benign are easily suppressed by just a little bit of elevated sinus rate. But in this ECG, you can see that the PVCs are quite frequent, despite the rate being high. Of course, the rate being high is because the patient is probably in heart failure. So I would believe the PVCs are at least until proven otherwise shouldn't be considered benign.
Okay, good.
All right, as promised, I show you the pro-BNP, which is markedly elevated in this young guy. So we have a normal thyroid function, normal troponin, so probably not acute myocarditis at this point of time. X-ray is normal, ECG all highlighted by Dr. Choi. Let's see the next slide. Choi order an echo. So maybe I ask Dr. Kannan. Hopefully my
Okay.
does it play? The GIF. Yeah.
It looks good.
Okay, I think Dr. Kannan, slide couldn't play, but from
Okay, never mind.
just the
From what you have,
technical
from
picture,
what
you
you,
can get a diagnosis.
yes, I think you showed me this picture earlier, and basically what your echo showed was poor LV systolic function. There was global hypokinesia. I think when you looked at it, we thought the RV contractility was also reduced. Now, very grossly, the mitral valve and aortic valve look grossly normal. Of course, we don't have any color flow Doppler pictures for us to study to see whether there's significant mitral or aortic regurgitation, but I think pictures that there were none of this. So these are someone where the LV function was very poor, and so this is very dilated cardiomyopathy.
All these findings, there are lists of differential diagnoses. Next slide, Dr. Allen. So, of course, with the history of previous COVID infection, so we thought of myocarditis, but it probably is not acute because the TRAPT is normal, but it still can be a post-myocarditis related cardiomyopathy. Means that the scar already set in and then the heart muscle become weak. And of course, the differential include a dilated cardiomyopathy, a non-ischemic dilated cardiomyopathy, usually idiopathic or genetic. And when we see a lot of arrhythmias, especially this PVC is so frequent, we know that this PVC can induce some form of cardiomyopathy. But as mentioned by Dr. Kannan, if you're able to eliminate this PVC, the cardiomyopathy can improve over time. Less likely, but not totally impossible, is ischemic dilated cardiomyopathy, even in a young guy, something that we have to think about it. And rare things like infiltrative cardiomyopathy, for example, amyloidosis, sarcoidosis, and in patients that consume a lot of alcohol, then we may consider alcoholic cardiomyopathy, but less likely in this case. So next slide. Okay, next slide. So these patients, actually, there's no sign of peripheral congestion, but I just want to try a very low dose of diuretics for his size, like he's about 120 kg, and see whether it makes any difference or not, because the other two physicians have tried all the inhalers, nebulizers. So, and I started a sacubitril valsartan, which is Entrestor, a very low dose, 25 milligram twice a day, and small dose of beta blocker, 2.5 milligram OD, to try to suppress the PVC as well as for heart failure therapy. After a few days, when the BP is holding on, I add on another 2 heart failure medication, which is spironolactone and empagliflozin. Empagliflozin is another type of SGLT2. Surprisingly, after 3 days, the cough starts to get better. After 6 weeks of therapy that doesn't work. So I think all these treatments probably have made some changes. Next slide. Then I'll ask Dr. Choi, at this point of time, before discharging the patient, is there any other investigation would you do to narrow down the diagnosis?
Yeah, so we can summarize that we have a young chap who is rather obese, has heart failure. We still do not know the cause. He has PVCs as well. So the first thing I'd like to do is to quantify the PVCs. Chicken and egg, the PVCs, is it the consequence of the heart failure or is it the cause of the heart failure? So I'll definitely order a Holter. And also not to mention that sometimes the PVCs can come in runs, so you have runs of VT, then it will be a sinister sign as well. Other than that, we need something that can penetrate the heart. Maybe a cardiac MRI would be good. Why would we want to do that? We already have an echo, right? So not just looking at the EF, the cardiac MRI can tell us a couple other things. For example, the scar burden of the heart. If you see a lot of scars, it may be a bad sign. Any infiltrative heart disease like sarcoid, amyloid, any weird structural problem like LV non-compaction, these all may be additional values or etiologies of a heart failure, that young person like him.
Yep. Thank you, Dr. Choi. So this is what exactly I do. So the next thing I order, next slide, would be the Holter first. To quantify the burden of PVC. Next, I think in the interest of time, I'll just go through the Holter. So next slide. So what you can see is a very high PVC burden, about 30,000 per day. So that basically translates into almost more than 20% of PVC burden. Now, in our previous webinar, we had mentioned that if very high PVC burden of 10 to 15% and above, it is associated with arrhythmia-induced cardiomyopathy. Now, in this case, it is very high. So definitely, we have to think of this association. There's also 3 episodes of non-sustained ventricular tachycardia. And this is actually very important, especially in someone with a very low EF, that we have to start thinking whether a primary prevention of sudden cardiac death due to ventricular arrhythmia should be implemented earlier, whether this patient should be implanted ICD first. Okay, next slide. And of course, cardiac MRI is very important, as explained by Dr. Choi. A lot of people who think that just a non-ischemic dilated cardiomyopathy is just a single entity. Actually, there's a lot of types of non-ischemic cardiomyopathy. There's infiltrative, there is genetic causes, idiopathic, myocarditis, so on and so forth. Now, very interesting that the MRI shows a increase in the LV size, poor EF, and also there's non-compaction in the left ventricle. What do you mean by that? If you see the, easier to see on the diagram on the right side, a normal muscle wall, there's no trabulation. where in the LV non-compaction, which is a genetic disorder, the muscle become like a sponge form. So in the olden day, they call it what the spongiform cardiomyopathy. And of course, this LV non-compaction will tell us that the prognosis is a bit poorer, and differential diagnosis will be the usual idiopathic non-ischemic dilated cardiomyopathy. Now, so the strategy changed straight away. Next slide. Next slide. So this patient has a very low EF, non-sustained and high PVC burden, and the initial suspicion is a non-LV non-compaction. Then the strategy changed straight away from arrhythmia-induced cardiomyopathy to non-ischemic cardiomyopathy causing PVC instead. So now we know probably the chicken come first. Dr. Choi. Next slide. How would you treat this patient? So would you put an ICD first, or would you ablate the PVC first? Treat with medical therapy first, Dr. Choi?
Yeah, so now seems that the PVC is probably the consequence of the heart failure, and the heart failure is because of a structural problem which the patient cannot find a reversible method. We will have to secure his risk of death first. I think given the EF is so poor, I would definitely suggest an ICD as a primary prevention for rhythm-related death, and also, of course, medical therapy on top of that to reduce the PVC burden and the VT burden.
Great. This is what I do first. In ICD first. Next slide. ICD first, prevent sudden cardiac death. That is most important, because a lot of times when patients on medical therapy, as they are improving, they are still not out of the risk of ventricular arrhythmia. So it's very sad if they're improving, but then sudden cardiac arrest while during treatment. So the next slide will show that I started all medical therapy, and because of a lot of PVC, sometimes it also will it will prevent the heart failure from being optimized. So I ablated the PVC, and you can see that this is actually the ICD interrogation. You can look at PVC singles, PVC run. There's a lot of PVC per hour, 457 PVC per hour. Okay, next slide. So I scheduled for ablation. And before ablation, it's important to check the coronaries. Next is a normal coronaries. And the PVC origin is very interesting area. It's not on the right side, the usual place. It is actually at the left coronary cups. Before we ablate, we really need to delineate actually where is the left main artery. If not, you're going to ablate at the osteo left main, and the patient going to get an acute heart attack on the table. Hence, why we do a coronary angiogram in patient with ablation contemplated on the left side of the heart. And the RFA of the left coronary cups was done surprisingly pretty easily. And the next slide, you can see that immediate after interrogation, the PVC becomes 0. In fact, the ECG subsequently becomes 0 PVC. I was also surprised. The outcome was so good. So next. So conclusion from this case is same as Dr. Kannan. Sometimes chronic cough can be a presentation for heart failure, especially the mild heart failure. In young patients, many differential diagnoses need to be considered. And the treatment focus is the same, is to alleviate the progression of heart failure by medical therapy. In this case, due to the presence of high PVC burden, PVC ablation was done. And number two, also need to consider the prevention of sudden cardiac death due to arrhythmia with implantation of ICD as a primary prevention. And cardiac MRI in this case has shown to be very useful in differentiating a type of non-ischemic cardiomyopathy. Now, if we don't have cardiac MRI, sometimes most of us will think that this is just a normal non-ischemic cardiomyopathy. They will start medical therapy first and see whether the arrhythmia improve or not. They will probably schedule for PVC ablation first. But you know that LV non-compaction or certain type of cardiomyopathy is something that is non-reversible. It only get worse with time, and then they are very high risk of sudden cardiac death. So this changed the treatment plan to ICD first and then treat with medical therapy and PVC ablation. Thank you. This is my case.
Okay.
Okay,
Okay,
Dr.
good.
Koh,
I
can
think
ask
we
you
have
one
got,
question?
Yep.
Oh, no time.
Sure.
I think we move on quickly. If we have got time, we come back. I think we got less than 15 minutes to finish. Is that okay?
Yeah.
Okay. This last case, we'll try to go through it quickly. Seen in February of 2017, referred by the physician, 46-year-old Chinese lady in coronary care unit with recurrent cough and hemoptysis. She was treated for as pneumonia for 48 hours. There was no improvement. She became progressively more breathless. When you review the history, she had had effort dyspnea for about 6 weeks. There was recurrent cough for about a month, no fever or weight loss, and for 2 days she had been coughing out blood. On prompting, she said that she felt more breathless when she lay down for 2 days prior to coming to hospital. There was no history of chest pain, no fever. She had been diagnosed with high blood pressure after the birth of her child 7 years ago. She took medicines for 2 years, but she had defaulted treatment for 5 years. No history of diabetes, she never smoked, there's no family history of heart disease. So first question to you, Dr. Choi, just based on the history alone, what are the possible diagnoses that run through your mind?
We have a 40-plus-year-old lady with hemoptysis. I guess we should think in line of infection like pneumonia or a bit more chronic kind of infection like TB. If she has not been moving well or hormonal pills on, maybe a pulmonary embolism as well. Had she been a smoker, or even a non-smoker, we should also consider lung malignancy. The fact that she had a bit of a dyspnea-like symptom, heart failure could also be a possibility.
Okay, thank you. In the interest of time, I think this summarizes all you have said. We'll move on. And still with you, could you offer some reasons for the hemoptysis?
Yeah, so depending on the cause, if you have infection, then, I mean, if she had infection, then of course the infective areas would have eroded some of the vessel that would lead to the blood in the sputum. Pulmonary embolism can cause pulmonary infarction. Sometimes heart failure can come in form of so-called hemoptysis as well, but those are a bit more florid type where they come in with pulmonary edema.
Okay, thank you. So when I examined her, she said she felt more breathless when she lay down. And in front of me, she was coughing out a lot of frothy, bloody sputum. Her blood pressure was elevated 150 by 110. Pulse rate was 110 per minute regular. I could appreciate pulses alternans. The jugular venous pressure was slightly elevated. There was no edema. I was unable to feel the heart borders. I could hear only dual heart sounds. The lungs, there were quite coarse crepitations up to the mid zones bilaterally. In the abdomen, there was no organomegaly. So back to you, Dr. Choi. Could you tell us what is pulsus alternans and what is its significance?
So, truth be told, I've never been able to feel the pulses alternans myself, but I would say that it is a variation of the cardiac output for each beat, which may alternate. So I guess if you were to feel and palpate the pulse, one beat would be more palpable than the other beat. If you were to use a sphygmomanometer, you will probably be able to hear two different types of systolic pressure. And this could be indicative of a heart failure because theoretically speaking, when you have more blood after the first beat due to the end diastolic volume, Frank Starling law says that you have better contraction. So the next beat should be stronger. But honestly, I don't think I'm skillful enough to actually feel one.
Okay, so essentially, whenever we feel it, it tells us that the LV systolic function is poor. And so, what diagnosis would you consider in this lady?
At this point, given all the points that you mentioned earlier, I would say heart failure should be top of the list. And considering her pressure to be so high, maybe something to do with her hypertension as well.
Okay. When we discussed this case, Dr. Koh brought up an interesting point. He said the blood pressure that we read was not really that high to cause heart failure. So how could we explain it? And so as we thought about it, one explanation could be that her pressure was actually much higher earlier. But as she slipped into heart failure because of the cardiac dysfunction, the pressure actually became lower by the time she presented to us. And we have seen patients presenting with heart failure where the BP is actually low, and we have to support it with inotropes, and as they improve, the pressure progressively increases to the point that you have to give antihypertensives. So that's something for us to think about as well. So what preliminary test would you like to do, Dr. Choi?
First, I think we should do an ECG, and perhaps a chest X-ray would be informative as well.
Okay. All right, Dr. Ko, I think you have to do some work now. Can you tell us about
Alright.
the ECG?
So again, this ECG is a sinus rhythm ECG. The rate is mildly tachycardic. You can see that it's almost like 100 beats per minute. So probably a bit of sinus tachycardia there. That's the rate. Rhythm is regular, so it's a sinus tachycardia. Now let's look at the QRS. The QRS, for me, it looks doesn't fulfill the left ventricular hypertrophy criteria. But if you see there's a T inversion in V4, V3 to V6, T flattening in every other leads, so means that there's a strain on the heart. So I would still think that this patient has a bit of left ventricular strain pattern, and the axis is slightly deviated to the left in sinus tachycardia. All right.
Okay, good. I mean, you've covered everything. We also thought that maybe there's a bit of left atrial enlargement. If you look at V1, it's in fact, quite negative. Yeah. All right. So this is the chest X-ray, and I think you want Dr. Ko, you can tell us about the
This
X-ray.
one, I think everybody can see is the gross cardiomegaly. Probably no need to measure the cardiothoracic ratio. On the left side of the lung, you can see some fluid in the fissure and a bit of interstitial opacity, indicate probably there's some pulmonary congestion. The right side is a PA view, will usually give a more accurate cardiothoracic ratio. Both obviously is very big cardiomegaly with the sign of pulmonary congestion.
Okay, thank you. So we did an echocardiogram, and maybe I want to tease Dr. Ko, can you predict what the echocardiogram will show?
Yeah, I expect a dilated LV with poor EF and maybe some dilated LA as well. Because ECG shows that.
Okay, let's see whether we can run it here. Okay, it's moving. So unfortunately, we couldn't get this patient's echo done 7 years ago. But this is from a patient who had a similar problem as her, hypertension and presented heart failure. And Dr. Ko, you want to comment?
So it's a poorly contracting left ventricle. There's no measurement here, but we all see a lot of echoes. We know that it is a dilated LV, LA, and some mild mitral regurgitation. Usually it's functional due to the dilatation of the annulus.
Okay, good. We'll just move on, yeah. So Dr. Choi, what would your diagnosis be now?
So at the moment, I think she's having some form of dilated cardiomyopathy. Personally, I think the elevated BP could be a cause. So maybe hypertensive related heart failure.
Okay. Since we are reviewing the diagnosis, Dr. Choi, could you tell us, are there any special features in the history that point to heart failure as being the cause of a persistent? So somebody comes to us with a persistent cough, and we always think it's something to do with the lung, but are there any features in the history that will warn us, hey, this might be more than just a simple cough, maybe it's a heart?
This is a very interesting question. Like what you have highlighted earlier in your history, her cough is mainly when she lies down. So I would say it's some form of autopnea, and we all do know that when we lie down, the lung is no longer vertical and horizontal, so the water spread is almost even. So in a patient who is congested, the oxygenation could be very much compromised at this position. So that may explain her cough, which is usually more remarkable at night when she lies down. And that should give us a clue that this is probably a form of heart failure.
Okay, so cough that's worse when they lie down, feel better when they sit up is a clue to think about. The other thing, of course, is effort dyspnea if they complain, yeah? Okay, so these are the following things in treatment. The patient was on an IV drip because the treatment initially was for pulmonary infection. So this was stopped. We gave her a little bit of furosemide 25, gave her also a spironolactone 25. And then you must remember that this is the days before Entresto and so on and so forth. So we used old-fashioned losartan to try to control her blood pressure. This is an ACE receptor blocker. The next day, she had passed out a huge amount of urine, almost 5 liters, with just the 20 milligrams of furosemide and the spironolactone. She felt much better and the cough was reduced. Following this, we gave her a small dose of a beta blocker in the form of carvedilol, and she improved even further. Dr. Koh, any other tests warranted?
The young patient, I will sometimes screen for any renal artery stenosis or suprarenal mass. So I will order a ultrasound renal artery Doppler. Especially this lady has been presented with hypertension at such a young age, 7 years ago. So I'll probably order ultrasound Doppler.
Okay, so important to exclude a secondary cause. So the Doppler was done and this was normal. And I think we are running out of time, so I'll just skip this, yeah? So this going now fast forward to 2.5 years later, that October of 2019, she's much better, blood pressure is well controlled, and she's on a combination therapy of losartan and amlodipine. No diuretics because congestion, all that was gone. I show you the serial ECG. If you see the ECG in 2017 and 2020, in 2020, all the strain pattern that Dr. Koh told us about is gone. And if you look carefully at the electrical axis, it is also less of left axis, and the R wave voltages are smaller. So even by ECG criteria, we can see that left ventricular hypertrophy is shrinking with therapy. And this is a chest X-ray, admission X-ray, and 3 years later, heart has virtually shrunk down, yeah? And if you look at the echo numbers, on top you have the LV in diastole from 65, which is very dilated. It has come down to 47.9, which is well within normal. And if you see the LA size also decreased, and most importantly, the ejection fraction has gone up from 25 to 60%. And I hope the echo will run. This is the echo when we first started. And the second one is the echo during follow-up. You can see that left ventricle is contracting very well. So final diagnosis is heart failure due to hypertensive heart disease, and there's reversible left ventricular dysfunction. And before we end, ladies and gentlemen, this afternoon's case, to a few take-home messages. A persistent cough may be due to underlying heart failure. The cause of the cough is pulmonary congestion and alveolar edema, which might not be apparent as X-ray, as Dr. Choi and Dr. Koh have pointed out. And classical signs of heart failure may not be initially apparent, and we need to maintain a high index of suspicion. And increasingly, we do more and more NT-proBNP to help us differentiate. Thank you for your attention.
Thank you, Dr. Kannan. So I think we've got a few minutes for Q&A. Just a reminder where to post your questions in Slido, 4142879, or you scan the QR code there with your QR code scanner or camera. Let's see whether we have any questions. Not much. Dr. Sunita says, as a GP, what criteria should we look for to send to a cardiologist and not to a physician?
A bit difficult to answer that. I suppose both will do an equally good job. So I don't think you need to differentiate right at the beginning. A physician, I'm sure, will be able to pick up, and if he thinks that he cannot handle, then he will send to someone who is more specialized. So don't really have to sweat over it.
Ventricular burden of concern. What is high? What's not high?
The ventricular atopics, PVC burden.
PVC burden.
So again, I mentioned earlier, but I'll just need to share with you that any ventricular PVC that is more than 10 to 15%, so that's based on a lot of observational trial, it is associated with some form of cardiomyopathy. So any burden, again, 10 to 15% and above. So you have to be a bit careful. Not exactly that you need to jump into treatment immediately, but the key point is always uh, uh, go for close observation, especially doing echo every 1 or 2 years to make sure the LV and LA is not dilated. And there's a lot of equipment or gadget, maybe Dr. Allen will know, that you can actually monitor your PVCs. Of course, you cannot calculate the burden. For example, if you have something like a watch, then you can see every day you got 1 or 2 PVC, but as time goes by, you got more and more PVC, you know that your burden keep on increasing. So PVC also something very dynamic. Dynamic means that if you document down 5% now, 5,000 a day, doesn't mean that 2, 3 years down the road it will be 5,000 or 5%. It may increase to 10,000 or 15,000.
Any advice for the GPs? Because the topics are so common. So if we keep on doing ECGs, we see more than 1 in 10. Is that a sort of like guideline or something?
So far there's no guideline. So any PVC that is like, for example, in the ECG that shows bigeminy or trigeminy, that means quite a lot. Any PVC that patient complain of symptoms, shortness of breath, giddiness, or the worst is fainting episode. If you see a patient fainting and then with a PVC, that should alert. Of course, as highlighted in many cases, any PVC with symptom of heart failure, then this is a red flag again. If you are having family with sudden death for no reason at a young age, especially, and you have PVC, there's also something that trigger a red flag.
Can I just add something? Is PVC also a cause of cough? Because the cardiologist told me this. You know, it's still they cough. Is that true?
I couldn't recall, but PVC does cause a bit of burping and bloating symptom. That's the rather atypical one that I always hear from my patient, apart from the usual one, like palpitation, misspeak, giddiness, bloating sensation. Yes, I don't know whether Dr. Choi
I think
encountered the same thing.
not too uncommon as well. Some of these PVCs can give you a sensation of cough. I think it's probably because of the pause and the extra preload. I think more common would be PACs. PACs, I think, more common associated with cough.
Okay,
I would like to add something very quickly before we end. Now, in the old days, before we had a lot of these sophisticated investigations, patients are occasionally seen with PVCs. We do a treadmill. If the PVC is completely suppressed, we used to say, this is benign, don't have to worry, don't have to come back. Now, I learned a very painful lesson about 10 years ago. There was this lady we saw 20 years ago. She had no other symptoms except the ECG showed some ECGs. Some ventricular ectopics. We did a usual test, nothing to be found. So I said, don't worry about it. And she never came back for 10 years. When she came back 10 years later, she was still having PVCs, but now she was breathless. And when we investigated her echo, which had shown normal function, now showed an EF of just 10%. So occasionally patients, like what Ko has mentioned, the PVC burden may increase, and over time, this might cause trouble. And lucky for us, this lady had a PVC ablated by Dr. Ahmad Niza, and we're very grateful because after about 2 years, EF had about 20%, up to about just below 50%. So, okay, thank you.
Okay. So we've come to the end of the webinar. Thank you for staying with us right to the end. And before I show that again, please don't forget to like the video and subscribe to our channel. Thank you very much, so that you can help propagate this great, I think, very informative, educational webinar by liking and so on. It will tell the YouTube algorithm to show it to more people and your colleagues. All right. So mind you, we can no longer show you a QR code to scan with your MMA app. So this QR code is just a link to the attendance form. All right. So if you have a browser, you can go to docs.my/030224, which is today's date, or scan with your QR scanner camera app. Sometimes some phone camera scanner can scan that link, get that code, and it will take you to that link. Then you fill in your details, and the SJMC coordinator will upload your attendance, and I think this will be valid for until today. So I have some good news also. We figured out a way to help you guys who are watching like 1 day later, 1 week later, and you have not watched before and you want to claim CPD points. What we'll do is reverse scanning. So we need you to acknowledge your we will take your word for it that you watch the whole thing. So we trust you. So you put a comment to this YouTube video that I confirm that I have watched the whole video, and we believe you, but we need your details so that we can do reverse scanning. So to confirm, you will need to send in your YouTube username, your MMC number, and then later we will ask you to, your MMA app. Sorry, it has a QR code. That is your personal QR code in your MMA app, and then we will use the scanner to scan that your attendance in. This will be from tomorrow onwards only. For today, please use this attendance link, and then we will upload one whole batch. But it's quite tedious to keep on uploading, so if you're watching this after the 3rd of February, that means from the 4th of February onwards, look out for a pinned message in this YouTube video, and then the instructions will be there on what to do. Okay, so even if you missed it, at least you just follow the instructions. I'll tell you exactly what to do, what details you need to send to me. And docs members, this is only for docs members, it's only for the medical doctors. I'm sorry, the others like pharmacists and dentists and anybody else watching, we can't do it. It's only for the medical doctors using the MMA app. We will need you to send the details and confirmation as a comment on the YouTube video that you watched it, and we will help mark your attendance. So this will be valid, right, until 30th of June. All right. So anyway, we've come to the end, and we wish you all thank you very much and a happy weekend. And we'll see you in the next one in April for the next grand rounds. Okay, so have a great weekend, everybody. Good day. Take care. Bye-bye.
Thank you. Thank you. Happy New Year.
Happy New Year and
Happy Chinese New Year. Kong Si Fa Chai.
Kong Si
Yes.
Fa Chai. Kong Si Fa Chai. Okay.
Thank you.